We shall now go on to our next speaker, Dr. Sunita Dube, who again heads the glaucoma clinic at the Shroff Eye Charity Center and is again a very dynamic surgeon. And she is going to tell us something even more curious and not too common, the persistent bugbear, aniridia and other angle segment dysgenesis. On to you, Dr. Sunita.
Thank you, Dr. Chitra. I'll be sharing my screen. Okay, so I'll be mainly talking about aniridia because it's not possible to cover everything in 8 minutes. So congenital aniridia is a rare genetic disorder. It is bilateral and with variable expressibility and variable degree of hypoplasia or absence of iris. It is predominantly because of the PAC6 gene mutation, and since PAC6 is expressed in the cornea, lens, iris, and retina, mutation can result in a pan-ocular condition affecting anterior as well as posterior segment structures. Other genes involved are FOXY1, PITX2, CYP1, etc. And when FOXY1 and PITX2 are involved, there can be a combination of aniridia with Axenfeld-Rieger syndrome with associated systemic anomalies like dental anomalies, heart problems, or umbilical hernias. And CYP1B1 may present with glaucoma at birth. Glaucoma and aniridia occurs in approximately 46 to 70% of the cases. 2/3 of all aniridic cases due to PAC6 mutation are familial, displaying autosomal dominant inheritance, and the remaining 1/3 are sporadic and non-familial because of the de novo gene mutations or deletions, and sporadic deletions of PAC6 contiguous with WT1 gene can result in Weger syndrome, which is Bill's tumor, aniridia, genitourinary abnormality, and mental retardation. So the patients with Weger syndrome need to be monitored on a continuous basis, at least for a defined period, at least till 10 years of age, and ultrasonography of the abdomen should be done to rule out Bill's tumor. A small percentage can be autosomal recessive, which is associated with some syndromes. So as far as the ocular spectrum of classical aniridia is concerned, there is complete absence of iris, and there is presence of the spanness or absence of a well-defined demarcated limbus, and which can progress to aniridic keratopathy. Then other very common features are foveal hypoplasia, optic nerve hypoplasia may be there, cataract, ectopia lentis, nystagmus, MGD, and microcornea. So this is a table showing prevalence of various findings, and as you can see that aniridia in aniridic children, reduced visual acuity and iris hypoplasia are present in 100% of the patients, and the other common features like cataract, foveal hypoplasia are also very common. The systemic associations like Weger syndrome, Gillespie syndrome, auditory deficits, diabetes, and pineal gland hypoplasia may also be there. Aniridia-associated keratopathy is one of the earliest signs to be there, and it initially presents as a circumferential and peripheral opacification of the epithelium and subepithelial layers, with vessels advancing into these areas from the limbus. And over a period of years, this spanness extends centripetally and eventually opacifying the entire cornea. It's very important to know the grading of this aniridic associated keratopathy, and to begin with, in stage 1, when you do not see very obvious findings, fluorescence staining should be done, and it will be manifested as increased uptake of fluorescein both in the conjunctiva as well as cornea. And it's important to treat the patient at this stage with a lot of lubrication, cyclosporin, and maybe autologous syrup to prevent progression of the keratopathy to some extent. Cataract is again very common, and 50 to 85% of the patients usually during the first 2 decades of life develop cataract, and in later stages it may subluxate superiorly. Glaucoma associated with aniridia doesn't present so often at birth, although defective iris is apparent at birth, and it develops in late childhood or early adulthood. And infantile cases are obviously because of the trabecular dysgenetic anomaly. However, the late onset glaucoma, it is mainly the anterior stroma of iris which sweeps over the trabecular meshwork, and you can see the absence of Schlemm's canal or abnormality of TM and development of synechia or ridges between the iris stump and the angled wall, which the anterior rotation of the iris stump leading to complete closure of angle. First line of therapy is the medical therapy, and then there are various surgical options. Prophylactically, one can perform goniotomy, and Dr. Walton has a large series wherein it was very successful before development of glaucoma. TRAP plus TRAP with mitomycin C gives variable results. However, it's important to perform a limbal-based conjunctival flap because there is a limbal deficiency of stem cells, and also it's important to prevent shallow ACN hypotony immediately post-operative because it can be disastrous. There's no iris barrier and there can be direct touch of the lens to the cornea. So releasable sutures are preferred and try to prevent hypotony post-operatively. TRAP plus TRAP if aniridia is associated with congenital glaucoma, and GDDs are preferred options, especially in cases with scar tissue at the limbal area, and cyclodestructive process as the last resort. So Dr. has already shown this procedure. So in this particular patient who was having aniridia with congenital glaucoma, I performed goniotomy as well as trabeculotomy in this patient, and the media was hazy, the view was not very clear, and so the rectangular scleral flap was made and it was dissected into the till the limbus, and radial incision is made over the Schlemm's canal, and then with the Harm's trabecular tool, the trabecular incision is performed by entering to the Schlemm's canal on either side, and then the suturing, conjunctival suturing. So I would like to discuss 2 or 3 cases. This was a 2-month-old child who was brought to me in 2009, and he was diagnosed to have congenital glaucoma with buophthalmos in both eyes. And on examination, the corneal diameter was slightly higher in the left eye, 13 millimeter, right eye was 11. And the IOP was also high. There was aniridia, cornea was hazy. TRAP plus TRAP was done in this particular patient in 2009. And he had a very good follow-up with me. And till 2017, his pressures were maintained. However, in 2018, he developed this cataract in the right eye and left eye superior-nasally subluxated lens. So he underwent cataract surgery and then membranectomy, and the pressure became very high in the right eye, and eventually he underwent ADI implant. So the surgery controlled the pressure, but as you can see in 2019 and 2021, there was progression of keratopathy. So these are progressive cases, and if there is keratopathy and if there is progression, then you expect PAC6 mutation. This is the IOP which was controlled after ADI implant also. Another patient, both eyes aniridia with subluxated lens and grade 2 keratopathy in both eyes. And TRAP plus TRAP was done in both eyes in 19 and 20. And the TRAP with TRAP is working really well, and she has been under control for 3 years. This is the last case. The patient presented to us at the age of 4 months, and he had microcornea with partial aniridia and cataract in the right eye with epithelial edema, and in the left eye, total aniridia with lens luxation. So he underwent TRAP plus TRAP followed by lens aspiration in the right eye. Left eye, he developed RD in 2021, and for which he VR surgery with lensectomy and oil retention sutures. However, after silicone oil removal, the pressure went very high, and eventually he underwent GDD implantation. And right now he is doing well with the well controlled. So associated glaucoma is really difficult to manage and often refractory to medical and some of the surgical treatment. Outcomes are better if diagnosed and managed early when there's not much changes. And long-term follow-up is required for these children and close compliance and follow-up is needed to improve prognosis. Thank you very much for your kind attention.
Thank you very much, Dr. Sunita. I would ask just one question to you. When would you take a decision to do a goniotomy? When would you do a trab? When would you do a tube if a patient comes with high intraocular pressure in these cases?
In Anaerobic?
Yes.
So Anaerobic, actually goniotomy is not very successful when it is not successful as a therapeutic procedure. It is successful as a prophylaxis, but we are not doing as a prophylactic procedure. Dr. Walton has a very big series, and if it is associated with congenital glaucoma, first surgery of choice is trab plus trab with mitomycin C, and if the child presents late, so still first surgery of choice for me is trabeculectomy, even if the child presents later in the early adulthood or late childhood. And if the trabeculectomy fails, then I would go for tube implant. So in NIRD also, I first like to do trabeculectomy with mitomycin C or trab plus trab, depending on when the child is presenting.
Thank you. Murli, you have anything to ask before we go on to the next talk?
Yes, madam, what is the dose of mitomycin that you use for these patients when you do a trabeculectomy? I mean, do you use a higher dose or injectable or anything?
The children, the difference is that one can use 0.4 milligram per ml. And in children, I tend to use both subconjunctivally and substerally, as opposed to adults wherein I use subconjunctivally mostly. So, and for 2 minutes only, I don't increase the duration.
Okay, thank you very